Nodding Along podcast. I'm your host, Emma Thomas, and this week I am welcoming Tina Backhouse. Tina's a general manager at Theramex and has over 25 years of experience in global senior leadership roles in the pharmaceutical industry. She brings an experience of launching innovative products across diverse therapy areas with both large and small pharma companies. And she joined Theramex in 2020 to lead their UK women's health business, helping to establish them as the largest supplier of HRT and menopause products in the UK. She's passionate about equality of care for all women regarding their health and in the UK, and that women have choice in their healthcare options. Welcome to the podcast.
Thank you, Emma. Nice to be here. Thank you.
And you come to us fresh from the latest all-party parliamentary group on women's health meeting yesterday.
Yeah.
So maybe we can dive in there. What does that involve, and what sort of things are being discussed at this point?
So the Women's Health APPG obviously looks at different things regarding women's health on different subjects. And the meeting yesterday was about putting a spotlight on menopause. So they invited a wide variety of stakeholders. So there was people from RCOG, some pharmacists, people from the Royal College of Nursing, Dr. Nigat Arif was there. There was some a patient who, or a woman, we don't really like to call menopausal women patients because they believe they are patients, but there was a woman there who spoke very eloquently about her experience of accessing menopause care and the impact it had on her. And actually her experience of accessing care was not that bad. It was pretty, she saw a GP, the GP happened to be the GP that was interested in menopause, and 3 weeks later she was settled on HRT, which is a really, we were trying to make the
good
point
outcome.
That's actually a really good outcome and not one you hear about that often. So, and Kate Muir was there, who obviously journalist and the producer of the Davina programs as well.
Yeah.
So it was really interesting to hear the Royal College of Gynecology talk about menopause from their point of view, the woman who spoke about her own individual, and of course Nigat, who is speaking very much on something I feel very passionate about the diversity of and how we reach diverse groups of women. And it's all very well. One of my pet hates is that people go, oh, I'm sick of hearing about the menopause. Everyone's taking menopausal products. Well, if you're white, middle class, Guardian reading, that might be true. But we know that Black women, for example, only about 5% of them are taking HRT, compared with over 20% of white women. And we know that women who live in socially deprived areas are less likely to be prescribed HRT. And when they are prescribed HRT, they're not as likely to be prescribed the newer types of HRT or transdermal HRT. And look, we always say these things, so it's not just about HRT. HRT is one of the things that can help menopausal women, but it's more about how these women are accessing menopausal care and what really needs to happen, and to try and get some outputs in a group like that when they, the chair, who is Sherilyn McElroy, who's a Conservative MP for Cornwall, will try and get some outputs that she can then go to the Minister and the Secretary of State and really push for on this.
Because they don't even have a menopause clinic anywhere in, is it Devon and Cornwall?
No, I know.
So
when I was sort of talking to Amantha, there's nothing in Devon, right? I'm not sure there is in Cornwall either. I'm actually from Cornwall, but I'm not sure that there is anything in Cornwall either. So, and there's even in places where you assume there are there might be lots of private menopause clinics, but for women that can't pay or don't want to pay or shouldn't actually have to pay, frankly, and for this transition of their life, just as the transition in pregnancy or any of these things is just a normal part of our lives, and we should be given support. I think one of the interesting things, interesting but infuriating, if I'm honest with you, is that everyone around that table acknowledges the need for a public health campaign, and that needs to take it needs to be a really well thought through campaign that really, as Nigat would say, you have to fish where the fish are. So social media, Asian radio. If you're trying to reach different groups of women, we can't just do a few articles in the middle press and expect people to read that or to indeed to buy books about it. We need a really clever public health campaign. I think what is infuriating about that is NHS England have for the last, well, ever since we set up the HRT task force with Sajid Javid in 2021, they have been developing a brilliant public health awareness campaign and an education campaign. And
And there's
now,
no money.
and there's no money, and that team have been disbanded, and
Frustrating.
all the work that has been done. So yesterday, when everyone was saying we need a public health campaign, I was going, there is one, but nobody will. There's one ready to go
That's
that this
ridiculous.
team has put together, and nobody will actually do anything. They did it as part of the women's health strategy. The problem is the women's health strategy is a lot of very good words on paper, but there is no action because there's no money put behind it. Because whatever they say, NHS England do not think women's health is a priority.
And the money, I think, that was allocated for the women's health hubs, and sort of people got a bit excited, actually, in many cases is being siphoned off because it's not ring fenced. So
Absolutely. So we talked about that yesterday, and the MPs always really, they're all really stunned at this, and it's just
it's like, what did
hilarious,
you
isn't
think
it?
would happen? You're
And
just
what did
putting
you
money in a
think?
leaky bucket.
It happened with dentistry when they gave money to that. So with the odd exception of women's health hubs of places like Liverpool, first of all, it was nowhere near enough money. It wouldn't even touch the sides. And secondly, it has just been absorbed into the deficits of the ICBs. And if you look, there's a spreadsheet that you can go online and look at that is meant to detail how that money has been spent in each individual ICB. Most of them haven't filled it in, and if they have filled it in, they put really vague things like contraception. So there's no accountability for where that money has gone, and it wasn't enough in the first place, and two, it's just gone into the deficit because it wasn't ring fenced. So actually, there's nothing that has been there to fund the women's health strategy.
And I know you mentioned that Kate Muir, who's been on this podcast before, was there, and I know that she was sort of talking on social media about this, and essentially it just seems so short-sighted to not spend the money, given that they will potentially be saving themselves so much sort of further down the road. But I think it's that.
And this is always the difficulty in the NHS, isn't it? That strategically, it's the right thing to do, because if you're, it's about preventative medicine, about looking after women, about, protecting their heart. There was Craig Jones, who's the chair of the Royal Osteoporosis Society, was there yesterday talking very eloquently about osteoporosis, the need for fracture liaison clinics, which the service of fracture liaison clinics in the UK is embarrassing, compared to some other countries like Spain, for example. Less than 0.5% of health economies in the UK can offer fracture liaison clinics, and yet 1 in 2 women will potentially suffer osteoporosis. And if we had a proper health campaign that talked about the benefits of HRT, but also more than that, the benefits of doing strength exercise, doing keeping mobile, diet, cutting down on alcohol, all these things that would actually improve the health of women and actually save the NHS a lot of money in the future in terms of cardiovascular disease and diabetes
So many
and
things.
osteoporosis.
Yeah, dementia.
It's so frustrating, isn't it? Because it's just like, I've done this for 30 years and it's always been fairly frustrating, and the NHS has always been pretty much on its knees, but it's not on its knees anymore. It's flat on its face, and there's so many good people in there trying to do the best that they can do, but they really need some support in trying to help and support women as we move into an ever increasing elderly population.
And we have the largest gender health gap in the G20, which
massively. And we have there's economic, which I hate to talk about the economic things, but often government ministers will only listen to that. And we have a 35% gender pension gap in the UK, and yet by the time our children retire, they'll be at least 70, well, if not older. People are going to be older. We're meant to be 67, which just fills you with absolute dread, doesn't it? And I was talking to my son about this the other day. He was saying, I don't know whether to go to university or get a job. I said, go to university. You're going to spend the next 50 years working. Do you know what I mean? Don't be in a rush to get in there,
Yeah.
because that's what it's going to be like. And I do think we've got the worst gender pay gap, we've got the worst gender pension gap, and the worst gender health gap. We can't pretend that that is not the case. And even though people talk about menopause being over medicalised, which I absolutely reject, because otherwise, why do only 5% of black women even get any help? We have to make sure that we are supporting women at all stages of their life. And, just because we've had some great people like Kate Muir, like Davina, like Carolyn Harris do individual things off their own back, we can't take away the responsibility that the NHS has to look after women at this stage of their life.
Let's talk about the report that you've brought out recently. So it's called Tackling Unequal Access to Menopause Care.
Yeah.
You've interviewed, well, not you personally, I guess, but yeah, as a part of that process, interviewed a range of clinicians and allied healthcare professionals, including Dr. Katie Barber, I think, who's also been on the podcast a couple of times and is brilliant. But why did you decide to sort of invest in putting that report together? Because I think big pharma, in inverted commas, gets quite a lot of flack. Why, people might be a bit cynical about your rationale for doing that and just saying, oh, you're just trying to flog more HRT.
Yeah, I mean, the first thing is, look, we don't really need to do that to flog more HRT. The market's growing. There's more and more women coming forward, awareness, all those things. So, you could happily do nothing about that. I've always felt that as a company, and, we are solely focused on women's health and work with a really passionate team. There's not very many of us. We're quite a small organisation, but we're all women of a certain age, and we all feel a real passion and a responsibility, actually. I feel a responsibility to do something more that we can do. And I suppose it was really being exposed to people like Nigat and Dr. Ziza, and talking to the guys from, Dr. Faye Ruddock from the Caribbean and African Health Group, and all these different people, the Lowdown girls, all these different people, and really understanding that actually, if you're a woman, your access to health, it's not equal in terms of your access to healthcare.
Out there.
Yeah, and if you're a woman and you're a woman of colour, it's even worse. And then if you layer on social deprivation or any type of
disability, or
any type of disability, neurodivergent, even like people that are deaf or neurodivergent, ADHD, anything like this, then the statistics go down and down and down. And I just think that we do have responsibility to try and address that. Look, there's a lot of women out there who will say, I know everything about it. I've got lots of friends in this situation. I know everything about it, who can afford to go and have private menopause care. And that's brilliant. But there's a lot of women who can't. There's a lot of organisations like the banks, like Sainsbury's, who are doing fantastic stuff in the workplace and really pushing that agenda in the workplace. But then there are also women who work in really tiny organisations where they may be like 1 or 2 employees. And how are they getting the same support in the workplace? And the answer is they aren't really. And I know Wellbeing of Women are doing a lot of work around that, around trying to access SMEs and really support them in supporting women. So I think we just decided that we had this idea that it wasn't equal, but it wasn't backed up in anything. We always get challenged on that. I've been challenged a lot on that data, even though the data is the data, right? Sometimes people don't like that. So we went out and got that data. And then when we saw the data, we worked with a company called GPRX, who are brilliant. And it was them that came to us and said, oh, look at this HRT data. And I think once we got that, we then went to clinicians, like you say, Katie was one of them, to really try and understand that data and what it might be telling us. We know there's differences in ethnicity and religion, and we know there's challenges around different cultures. But, the stuff around women and in the poorer areas and around disability probably wasn't the stuff we know. And so that's why we did it. We did it because we wanted to understand, and we wanted to really be an advocate for those women as well. I feel like we are able to speak to those women. It's not just about HRT, it's about them having choices. I'm all about women having choices around their healthcare. If you never want to take HRT and you take supplements and you do loads of exercise and you do cold water swimming, which lots of my friends do, and it works for you, then that's fantastic. I'm really happy about that. But that because you have the choice, because you have the information. And lots of these women don't, and they get desperate. I mean, you only have to go on social media, which will break your heart sometimes when you
There's
go on
support
social
groups
media.
on
And
Facebook, and yeah,
yeah,
I'm
you
in a
read the
few.
stories, and I try not to let myself do that, but sometimes I do it. And I read the stories of
Give
what
you the fire to keep putting a rocket under things.
it does, really. And I just think what I don't want is, I don't want these women desperately walking around, a store and spending money they don't have on things that might not work for them without any type of support and knowledge. And I just think, Emma, education is the only real freedom we ever have, right? And education around our own healthcare is such an important freedom in terms of managing our own selves moving forward. So that's really why we did it. And then as we've done it, of course, other people like Carolyn Harris and the Eclipse group have come out with very similar data. So they've looked at the data and they've come to exactly the same conclusions. So it was just something to keep. I suppose in the beginning we thought it was another interesting area to keep the conversation alive, and now it's become much more than that, because it shows such inequity, which we can't. Once you've seen something, you can't not see it. Once you've heard something, you can't not hear it. You have to try and do something about it, whether that's to highlight it to ministers or to put it in newspapers. We can't pretend we don't know that, and just carry on selling as we've always sold. So that's why we did it, really.
Yeah, I mean, some of that data in there really is quite staggering. Sort of, from you are comparing in terms of sort of a deprivation index. So, and also looking at these, as you were saying, sort of numbers of ethnic minority
Yeah,
patients within sort of the area of that you were studying. So in some cases, I think you're saying sort of practices where there are the fewest ethnic minority patients were prescribed more than 3 times as many
yes,
HRT prescriptions as those in those with the sort of the most ethnic minority patients, and similar sorts of kind of ratios in terms
absolutely.
of those areas of deprivation.
Absolutely, and that can be within the same city almost. The Eclipse data showed this, that if you take somewhere that's seen as, relatively well heeled, like Cambridge, but Cambridge itself has areas of extreme
Same
deprivation.
here in Oxford, actually.
Exactly the same in Oxford, and Katie said that, didn't she? And that's what you see. You see that kind of disparity, and that's not right, because we all suffer anyway in terms of lack of equality. And when you've got daughters, I say this all the time. My mission is that my daughter is not having the same conversation in 40 years about this stuff. That whatever your color, whatever your creed, whatever your religion, whatever income you have, that you have the same availability of menopause care and support, whatever that looks like. But it's individualized care, and that's what women need to really. And it will have massive benefits, in terms of social,
Lifelong
women,
benefits as well.
lifelong benefits. Women are the biggest carers. They're the biggest unpaid carer. At this age, they're often looking after children and elderly parents or relatives. They've got a huge amount of pressures. They're leaving the workforce. 10% are leaving the workforce. And so that has an economic pressure that the country definitely cannot take because of lack of taxation. So all these things are incredibly important. And, we just have to make sure that whether you work in, whether you are the chief executive of Barclays or whether you stack shelves in Sainsbury's, you should have the same right to care and support and education that you understand and that is individualized to you in terms of managing your gynecological health.
Well, that's the point of the NHS, really, isn't it? Is that everyone has the same.
I always find it difficult now to say it's a national health service, because nothing could be further from the truth. Of course, it's not a national health service, and that is no way criticising anybody that works in it. It's just that there is no money and there's lack of resource, and people are doing their absolute best in the most dire of circumstances. But in those circumstances, that women's health often gets missed.
So let's have a kind of the report actually has 5 recommendations that come out of it.
Yes.
So maybe we can put our our rose tinted glasses on and look at the things that ideally, and maybe with a change of government later on this year, maybe some of this will happen. But so the first one is expanding the scope and coverage of menopause training as the current core curriculum for GPs, because unbelievably GPs don't have mandatory training in something that impacts 51% of the population. And my lovely sister-in-law is a GP, so I'm definitely not GP bashing.
No, not at all.
So yes, we can only hope that would at some point become
yes, because we know that at the moment that's not the case, and we know that when GPs are interested and they try to access things like the British Menopause Society has a brilliant accredited course, they have a huge waiting list for people to get on. That's people self-funding. So they can't get the training they need, even outside. So it has to be mandatory.
And it definitely is improving, but just not fast enough.
It's just not fast enough, really. And that's what we need to accelerate.
So the second one then is prioritising a local formulary for HRT. So if no one has heard the term sort of local formulary before, explain very kind of simply what that means?
So people often think, don't they, that a drug gets a license, it gets a price from the Department of Health, and then it's used, right? And that's not the case. And what happens is it goes down to local health economy levels, whether that's a trust of a hospital and groups of GPs, and it goes through this, even if it's NICE approved or SMC approved, it goes through this process, which is an inordinate waste of time and resource, actually, because
given that's what being replicated how many times across the country? Hundreds,
right?
Dozens.
So my argument has always been, if UCLL do a review of a product and they say we're going to put this on formulary, why do you then need every other hospital trust to look at it individually? Why would you not go, they've done the work, they think this is a good idea, we'll put this on our formulary? But that's not what happens. So the short reality of it is that it's very difficult to bring new medications into the market. It's very expensive. Women's health products tend to be really cheap to the NHS. They don't cost. Most HRT costs less than £10 a month. That's the reality. And but it's going to be really difficult for companies to bring into the UK market because it's so difficult to get products used.
You've got to jump through all the hoops.
It jumps through all the hoops. And also what it means is that newer products are being used, and women are having better choice of products in some areas compared to other areas.
Right. So you were talking before about some people not being prescribed the sort of the safer, newer forms of estrogen, for example.
And that might just be because it's not on their formulary.
Wow.
And I had this discussion in my own practice, where I had awful vaginal atrophy. I know we don't call it that now. I know we call it a really complicated
GSM, for sure.
Yeah, GSM. Yeah. But yeah, vagina, and where I was getting UTIs constantly, feeling terrible. It was really life debilitating. I went to the GP. They tried me on 2 or 3 medications that were on the formulary. It just didn't work. And then I went, having spoken to a menopause specialist. I'm very fortunate that I was able to do that, and said, can we try this? And I had to really fight. And,
and if you didn't know that, you would just carry on suffering.
But that's because I was really privileged. I knew I still had to fight. I still had a pharmacist ring me up at home and really challenge me on it. And it was a really big battle, and I knew what I was talking about. So I think, what we're saying is that in order for women to have, we should have a national formulary, which would take away a lot of bureaucracy. The
makes sense to me.
The British Menopause Society support this. You've got experts like the British Menopause Society who go, we've looked at this clinical data and this is where we think this product should be used. What more do you want to know? And that's really what we need to do. And we need to, because yourself, and you will have heard from so many women that HRT is so individualized.
Oh,
If I
yeah.
look at my own team, if there's like 4 or 5 of us on HRT, everyone's on something different, right? And because we're all different, we've tried different things. I've tried a myriad of things, and tinkered. I'm always tinkering with things myself. Don't tell doctors that. And
Don't do
but
that at home,
don't tell
listeners.
Kate. No, that is definitely not what people should do. And but we all do that, and so it's really important that there's a wide range of products available. And we saw the impact of this during the HRT shortages, because what was happening was people going, oh, all HRT was out of stock. Not all HRT was out of stock, but a lot of HRT that was being prescribed was
Right.
out of stock. And there were no other choices because the formulary was so narrow. So that's why we think that's important.
Okay. So number 3 is engaging more with local communities and the third sector to help sort of do that education piece and raising awareness. And I think, some sort of ICBs have sort of funding for those kinds of programs, but that sort of, national top-down funding would seem to make a lot more sense for that
And
kind of
that's what
thing.
has to be, really. I mean, we try and support, we're supporting our cog on some of the stuff they're doing, and well-being of women on some of their campaigns. And but really, again, it comes down to there being enough money in ICB level. And reality is it probably needs to be at least 4 times as much as the money that's been given so far for individual ICBs to make any impact whatsoever. At least that, I would say. And that was, a discussion we had yesterday. But that is really important moving forward.
The fourth one there, and I don't know how this overlaps with the first recommendation, is around sort of women's health education and training for GPs and the wider healthcare professional workforce. So I know some practices will have a sort of a menopause nurse, but again, certainly the ones that I know of, time for those is limited. So if we had more people that had that training, not just the GPs, but other people within those sort of healthcare settings.
Yeah. And I think that's the way forward. I mean, I am a massive advocate of pharmacists running HRT clinics. We know that in some areas, I know Rena, I can't remember her last, sorry, I've got terrible brain fog. I can never remember anyone's name. Rena is running one in Sutton, and that's a pilot. And, these people are really, pharmacists are great to be able to run these clinics, right? Because they know the women, they know the other medications they're on, they understand drugs, so they understand drug interactions. And until it's a measurable quaff, until it's a framework that GPs get paid. So GPs get paid to do diabetes checks, they get paid to do blood pressure checks, they get paid to do some contraception stuff, or like put coils in for contraception. They get paid for certain things. They do not get paid for menopause and women's health. So, and there's no HRT check. So there are some women, the NICE guidelines say that women who are on HRT should have an HRT checked annually. I know very few. I've been on HRT for over 4 years. I've never had an HRT check. Nobody's ever asked me. I think
unless you go and ask for it, you're very unlikely to be.
But we know that that's very important. So, we do feel that that's an important thing that, until look, what you inspect, people respect, right? And I do think until you actually make it important enough for GPs to say, okay, or even, there's so many opportunities for different people to get involved in the healthcare of women. For example, if you're doing over 40 checks with the nurse or cervical smears, just a question about, you're over 40 now, this is what might happen to you
or
in the next few years.
A leaflet that people could give out at
a leaflet, or a link to the British Menopause Society website, or whatever it is, just to educate yourself. I never knew I was in menopause, and I was 48, because I thought until you had a hot flush, that's when you would know you're in menopause. I've never had hot flush in my life, but I had aching joints. I was, terrible panic attacks, palpitations, couldn't sleep, but I never knew I was in menopause because I wasn't educated. And I think that, like I say, there's so many opportunities. We're not going to change the fact that there's not enough GPs. Everyone is having trouble accessing their GPs, but we just need to change how we manage women's healthcare in terms of there are pharmacists, there are nurses, there are people that could really make an intervention and give education to these women. Carolyn Harris is doing some great work in prisons. There are nurses whose job is to work in women's prisons who have no menopause training. And yet the most women in the prison will be of this age. So
Really?
simple things like that could make a massive difference. So we just have to get further than thinking it's important to educate our GPs during their mandatory training. Of course it is, but there is a wider healthcare community here who could really, and often, there are certain, what we do know is there's certain groups and communities who don't trust the GP, who would rather talk to their pharmacist or would rather talk to the nurse. And, to have that combination of healthcare looking after women is so important, I think, moving forward. And it's sustainable.
Catching people falling through the gaps.
Exactly, which is what we hope, any new government would, whether they're incoming or returning, would look at that and say, this is such a simple thing that would make a massive difference to 51% of the population.
And the final one is really maximising digital technology, which is revolutionising so much of kind of healthcare, to sort of, I guess, really support those GP consultations and improving access to care. So as we know, your average time on the clock with your GP is about 10 minutes. And if you think about the litany of, even just the number of symptoms that you've talked about there yourself, that's not unusual to have sort of that much kind of complex stuff going on. Trying to unpack all of that in a sort of a 10-minute consultation is nigh on impossible.
No, that's exactly right. And that's what Rena was saying yesterday. As a pharmacist running a clinic, HRT review clinic, she has half an hour with each woman, right? Now, that's significantly more than the average GP, as you said, who would have 10 minutes. And, GPs will say to me often, God, I'm so frustrated because the women will say, well, what about this? We have a conversation about this, and then they'll say, well, what about my vaginal issue? And I have to say, come back. You have to come back and talk to me about that. And that's such a waste of time, and it's not how we're looking after it. We also know, of course, there's huge amounts of social media, and we're being bombarded by data and information all the time. But we have a responsibility to make sure that it's accurate and clinically accurate, and not, feeding, wild claims and inaccuracy. So the NHS really, I think, from a technology point of view, there's so much that can be done digitally to really having a public health campaign is not just about, it's not really now about having TV adverts. It's not like, when I was at university and they had the HIV.
I'm not sure I even watch regular TV anymore.
Well, I said this to someone the other day, my children never watch television. I cannot even tell, they're teenagers. But it's about what we do on social media. This is why people like Nigat and Azizia are so influential in terms of talking to their communities on social media. We know that if you went to, have proper websites and proper points of information that were accurate and that women could go to, that we could pinpoint women to and say, look, this is where you get the latest information, and actually allow women to take control of their own health care and go, actually, you know what, I do have quite a few of those symptoms, and that's what I'm going to talk to my healthcare professional about. So it's really important that we use digital information in the right way.
Well, if anyone's interested in reading the full report, I think it is publicly available, so I can drop
yes,
the link into the show notes if you want to go and have a look. But so what's next in terms of your involvement, in terms of Theramex? Kind of, where do you go from here?
Well, we're trying to look, menopause will always be our passion, and but we are, we're women's healthcare, so our mission is to bring as many innovative products to the marketplace as possible, whether that's products that have been discontinued by other big pharma companies or products that are available in other countries, not in this country. We're moving into the area of uterine fibroids, and that's a really interesting area for us. We're working with ARCOG on their Not Just a Period campaign. And again, there's huge inequity with things like fibroids. We know that black women get fibroids much more than white women, and yet they're not seen. And this thing about normalizing, oh, it's just a heavy period. and so that will be our next kind of mission, I suppose. But it still comes down, it always comes down to the equality of women around all parts of their gynecological healthcare. So, and, we're always looking for innovative new products. And, I love it. On LinkedIn all the time, I constantly get people contact me about, weird and wonderful things. And I always talk to them, because who knows when the next brilliant product will come that will revolutionize women's health. So, so we will continue to do this and work. We like to work with different organizations, like I say, RCOG, Wellbeing of Women, Menopause Mandate, to really, support them in their missions moving forward, to really, pursue the goals of women's health.
That seems like a great point to finish up. Tina, thank you so much for your time.
Thank you very much. It's been lovely to talk to you.
You've been listening to the Middling Along podcast. Do remember to subscribe to be notified when our next episode is live. And why not visit the blog at www.middlingalong.com to sign up to my newsletter as well. I do hope you enjoyed listening today. If you did, I'd be really grateful if you would consider leaving a short review, as that helps people find the podcast and helps get it noticed. Hope you can join us next time. Goodbye for now.